I'd like to introduce Dr. Tuck. Dr. Keiran Tuck grew up in the United States and studied medicine at the University of Sydney in Australia. He completed his neurology residency and a fellowship in movement disorders at Oregon Health and Science University in Portland, Oregon. He has done research and published on palliative care and Parkinson's disease. He was the co-director of the Legacy Portland Parkinson's program, and he resides in Victoria, BC, and sees Parkinson's patients at the Parkinson's and Movement Disorder Clinic at Royal Jubilee Hospital. Dr. Tuck, welcome. Thank you so much for being here today. I will pass it over to you now.
Great, thanks, Alana. Thanks for having me. Can you hear me okay?
Yes, I can hear you.
Okay. Okay, great.
So we just want to have you spotlighted.
Cool. So I'm going to talk today about non-motor symptoms in Parkinson's. This is a talk that could be, could be probably hours and hours long. So we'll try to get through what we can in the next hour with some time for questions. So I'll just get right into it. I'm just going to share my screen with you because I've got a PowerPoint presentation here. What's happened there? Can you all see the screen that I'm showing you? Yeah, I can't, well, I don't hear anything from anyone, so I don't hear complaining. So I'm going to assume, yep, okay, people are saying in the chat, yes. Okay, great. So let's start with an outline. So we're just going to talk a little overview of Parkinson's. We'll probably blow through this pretty quickly because I assume all of you know the basics of Parkinson's disease. And then we'll talk about some of the common non-motor symptoms of Parkinson's, and then we'll talk about a couple specific ones, orthostatic hypotension and pain. So, you know, just a few terminology issues. Parkinson's disease, you know, is kind of classic Parkinson's disease. Then there's also lots of other Parkinsonisms, which can be caused by lots of different conditions, vascular disease, these Parkinson's plus syndromes like PSP, MSA, CBD, or Lewy body dementia. And then some people with other genetic conditions can have symptoms that look like Parkinson's disease. And then there's also drug-induced Parkinsonism. So today we're really going to be focusing on Parkinson's disease. We'll talk a little bit about these other Parkinson's plus syndromes. And I just wanted to, you know, just bring up this, this is the essay on the shaking palsy by William Parkinson that he wrote back in 1914, which was the first description of Parkinson's disease. And really in that description, he focuses mainly on motor symptoms, but he does talk a little bit about these non-motor symptoms as well. But certainly for a long, long time, for 150, 200 years, there was a lot of just focus on the movement part of Parkinson's. Hence, you know, why we call ourselves movement disorder specialists and we have movement disorder clinics is because Parkinson's was mainly thought of as a problem with movement. But over time, we've really learned that there are a lot of other issues that go along with Parkinson's that don't specifically have to do with movement. So some basics, you know, what causes Parkinson's? I mean, the long and the short is we don't really know. There's probably a lot of different dominoes that fall, genetics, certain environmental things that may cause Parkinson's. Interestingly, it seems that smoking and caffeine may be protective. You know, we don't recommend you start smoking, but there must be something about smoking that, you know, people who smoke are less likely to get Parkinson's. So a little hard to know what that means. So about 7.5, this is old data, so this is probably more like, you know, 9-10 million people in the world with Parkinson's these days. Typically comes on in your 60s. And then if we talk about the cardinal features, these are all motor symptoms, right? So the tremor, you know, or shaking, this is what James Parkinson called it. He called it shaking, but we call it tremor. What we call bradykinesia, James Parkinson called palsy. This is slowness of movements is bradykinesia. And then postural instability. what Parkinson would have called difficulty with gait and falls. And then rigidity, right, is this stiffness of movements that really Dr. Parkinson never really mentioned in his original monograph. So these are kind of the four cardinal features of Parkinson's disease. The main ones that we really think about and that most people are aware of are the tremor and the slowness of movements, right? But these other two go along with it as well. And these issues with movements are mainly related to problems with dopamine and dopamine pathways. And so this number one, this light blue, is the main dopamine pathway that's affected in Parkinson's disease. And this is, goes from this area, the substantia nigra, up into the basal ganglia here, this middle part of the brain that controls movement. But there are other dopamine pathways in the brain. There's this darker blue one that is related to kind of emotion and reward behavior. And then there's also a smaller one here, the really dark one, which is related to your hypothalamus, which is related to kind of hormones and things. We don't really think about that too much in Parkinson's disease. So I'm just going to go through this really quick because you all know this, right? There's a few different medications that we use for Parkinson's. And I think one thing to remember is that your medications can cause side effects as well. So, yes, Parkinson's can cause a lot of non-motor issues, but also your medications can cause it. So the levodopa can cause nausea, low blood pressure, extra movements, constipation. Some of these other medications, the dopamine agonists, can cause swelling of the legs, behavioral changes, excessive somnolence or sleepiness. And then some of these other medications that we use along with the dopamine medications, amantadine, tacopone, and the selegiline, rasagiline, can also cause other symptoms. So, if you're having non-motor symptoms, if you're having extra concerns about what's going, about your, I guess, day-to-day life, the first thing to think about as well, did I change any of my medications recently, or could this be a medication side effect? So this is kind of a partial list of non-motor features of Parkinson's disease, and it has a lot of different things here. Parkinson's we used to think of as a motor problem, but really it affects the whole body, or can affect the whole body, and certainly affects a lot of the brain. And since the brain controls the body, it can cause lots of different problems. So this is certainly not an exhaustive list, but this is a lot of the most common ones. And let's just kind of go through some of these. So drooling, the reality of drooling is everyone produces saliva. It's got to go somewhere. So for most of us, we swallow constantly. Or, when you're breathing and talking, it just dries up, right? But in Parkinson's, just like your movements slow down, your swallowing can slow down as well. And so the saliva's got to go one way or the other. It's either got to go in or out. And if it's not going in, it's going to come out. So one of the main treatments is, easy treatment is sugar-free candy or gum, things like that, in order to stimulate swallowing, essentially. Right? So if you have something in your mouth, it kind of stimulates you to swallow. And then if that's not enough, there are drops that you can use in your mouth that dry out the mouth. And then we also sometimes give Botox injections into the salivary glands in the cheeks or under the jaw to, again, dry out the mouth. Another common problem in Parkinson's, and usually kind of later on in the disease, can be swallowing dysfunction. And I guess I should say, look, not everyone with Parkinson's gets all of these problems, right? So as you all know, everyone with Parkinson's has a different story and a different path. And so these are all possible problems in Parkinson's, but they're not guaranteed problems in Parkinson's. So swallowing problems often come, kind of near the end of the disease and manifest with coughing or choking when you're eating or drinking. Again, this is a muscle problem. So sometimes the Parkinson's medications, the levodopa, will make this better. But often the treatment is really exercises, right? And strengthening the muscles in your mouth and your throat. So seeing a speech pathologist can be very helpful for this. Nausea Oh, so I've got a question from Susan. Can PD swallow issues begin sporadically? Yes. So they can come on kind of at any time, and but as I said, usually it's kind of later in the disease. But there are certainly patients who, middle of the disease, early in the disease, can have a bit of trouble swallowing. So, so yes, I guess it can come on sporadically. Yeah. So then nausea is a common symptom in Parkinson's, most commonly associated with taking medications, with taking your levodopa. And, one of the problems is you really need the levodopa, or most people need the levodopa. So this is one of these things that it's hard to ignore, and it's hard to just say, well, just don't take your medication, right? Which would make it go away. And so we really tried to say, well, try ginger. Ginger is a really well-known medication for combating nausea. Taking your medications with food. Now, I know often it'll say, don't take your medication with food, especially the levodopa, but the real key with that is protein is a problem with levodopa. So if you take your levodopa with meats or dairy products, then that can affect the absorption of the levodopa. So when we say take food with your medication, we mainly mean take, carbohydrates, crackers, bread, toast, simple things like that can help really ease nausea when you're taking your medications. And then if nausea becomes a more consistent problem, then there is a medication called Domperidone, which is a pretty well-tolerated anti-nausea medication that we commonly use in people with Parkinson's. And one thing that Domperidone does is it helps kind of push things through the gut. One of the problems that's not medication related in Parkinson's that can cause nausea is your kind of stomach slows down, your gut slows down, everything just kind of doesn't move as quickly. And if everything's sitting in your stomach for longer than it should, that can give you nausea. And the Domperidone essentially helps kind of push things through. So constipation, really common, is often a symptom that comes on before motor symptoms. So one question I often ask my patients when I first meet them is, do you have constipation? And that helps me kind of make the diagnosis, because a lot of people with Parkinson's will say, yeah, I've had constipation for 10 years or so, before I noticed a tremor or before I noticed any of my stiffness or slowness. So constipation, we sometimes talk of as a preclinical symptom, right? That you get it long before you were ever diagnosed with Parkinson's. And then it, can then kind of slowly get worse. It can also be a side effect of the levodopa. So levodopa can cause constipation as well. So, things to do to try to treat constipation: drink lots of water, exercise, and then, the next step would be something like fiber supplements, Metamucil or psyllium, or just eating lots of prunes and fruits and vegetables and things like that. And if that's not helpful, then we move on to what's called polyethylene glycol, or PEG. Now, I've put up a picture of Restorelax here. I don't get any money from Restorelax. I'm not pushing them. This is just kind of the most common brand name of this medication, but it comes in there's Laxaday, there's generic forms. And this is essentially a powder that you mix in with water or juice or something like that, and you drink it, and it essentially pulls water into the gut to help push your stools through, essentially. And so one thing we often talk about is that people are often worried about taking regular laxatives, because in the general public, we often say, don't take laxatives for more than a few days, and don't take them regularly, or else you get essentially addicted to them. But in Parkinson's disease, people need laxatives every day, and that's really common. So don't hesitate to take it if you need it. And I always tell people it's better to be proactive than to be reactive, right? It's always better to take something daily to not get constipated rather than wait till you're constipated and then have to try to play catch up. So I've just gotten a message that I freeze sometimes. I don't really know what to do about that. You guys miss something or I freeze for a long period of time, please just let me know and I'm happy to repeat things. So, talking about constipation moves us on to another good topic, which is autonomic dysfunction. So this is kind of a broad term. So your autonomic nervous system is the part of your nervous system that controls things that you don't think about. So bowel function is a good example of that, right? None of us think about our bowels moving and our bowels absorbing food and digestion. It's just something that happens naturally. But that's all controlled by your brain. And other things that are autonomic, controlled by the autonomic nervous system are your heart rate, and then some things that you're kind of semi in control of, like your bladder function. You're kind of in control of it. You have some control, but sometimes you don't have control. And then erectile function, things like that. So constipation is a common issue of autonomic dysfunction. So autonomic dysfunction in Parkinson's, essentially the autonomic nervous system, malfunctions, and that can cause things like bladder dysfunction, urinary dysfunction. This is often an overactive bladder. So people who go, have to urinate frequently during the day or frequently at night, or that feeling where you suddenly have to go, and if you don't make it to the toilet, you're going to wet yourself. So that can be a common problem in Parkinson's disease, right? Erectile dysfunction is also pretty common. So treatments for urinary dysfunction, we're not going to go into this in much detail, but there are medications you can take that relax the bladder. Someone's asked about Botox injections. So yes, that can be a treatment for this overactive bladder. It's a little bit invasive because they have to put essentially needles through your belly to inject it into the bladder. So generally, I recommend trying tablets before going that route, but I certainly have patients who get injections in their bladder for that. That can be very helpful, yes. Erectile dysfunction, I think one of the keys to that is if you have it, you got to talk to your GP or your GP or your movement disorder specialist or your neurologist, right? Because I find that a lot of people don't bring that up. It's kind of a touchy subject, and it's something that as a society we don't talk about very often. But there are medications that can help with that if that's a concern. So then the thing we're going to talk about in more depth is orthostatic hypotension, which essentially means low blood pressure, especially when standing up. So before I move on to that, I got a question. What's known about women and sexual response in PD? Yeah, so, there's not a whole lot of research in this area, but there is some. And certainly it can affect libido and can affect just like erectile dysfunction can be a problem, also, the kind of vaginal arousal can be a problem. I must admit, I don't know a whole ton about that area. I just know that it can be an issue. Generally, when I talk to patients about this kind of stuff and they're concerned, I would refer them on to a gynecologist, if they're a female, or a urologist if they're a male, to kind of talk more in depth, because those are really the experts in sexual function. So let's talk a bit about low blood pressure. So this is just kind of a map of your autonomic nervous system, just kind of showing that it affects everything, right? So, this is all the stuff that you don't think about, right? Your eye movements, your, saliva production, heart beating, your lungs working, your liver, your kidney, your pancreas, all that kind of stuff. So you can imagine if your autonomic nervous system is not functioning 100%, you can have lots of different symptoms. And one of the things that your autonomic nervous system does is regulate your blood pressure. So, I don't think any of us think about whether our blood pressure, we probably a lot of times don't even notice our blood pressure is low or high unless we're having a problem, right? Unless you notice, unless it's really high or really low. So in Parkinson's, the main issue really is it can be low. Essentially what happens is normally what happens when you stand up, the normal response is that your heart rate beats a little faster and your blood vessels constrict to try to push blood up to your head to make sure that your brain gets enough blood. And in Parkinson's, that doesn't happen as much, right? The blood vessels don't constrict like they should. And the heart rate doesn't go up like it should. And so you can have a lot of symptoms. The most classic symptom is this kind of feeling like you're going to pass out, right? And we've all had that, right? It happens to everyone at some point. You stand up too quickly, you feel like you're going to black out, and then maybe, whoa, you steady yourself and you feel okay. So that can be a symptom of this, but there are also other symptoms of your blood pressure being too low, right? Blurred vision, you can have headaches, you can have your heart racing, you can feel just fatigued. There's also evidence that if your blood pressure is too low, your cognition just doesn't work as well, right? You don't think as well. You're not as sharp as you used to be. So they've done studies where they'll give people like a test, a memory test lying down, and they have them stand up. And these are people who have low blood pressure when they stand up. They stand up, walk around a little bit, give them the same memory test, and they do worse when they're standing up and their blood pressure is low. So sometimes the symptoms are not as obvious as this classic, falling over and passing out. I've got a question. Is it an issue on the para or sympathetic side? I assume you mean the low blood pressure. And the issue is on the sympathetic side, right? So it's constriction of blood vessels, this kind of stimulation, fight or flight response. So the parasympathetic nervous system is the part of the nervous system that deals with kind of relaxation, right? Your gut function, when you're relaxed, right? And the sympathetic nervous system is when you're stimulated, right? And so you think when you stand up, you need stimulation to your blood vessels and your heart to make it work properly. And that's not working as well when you have low blood pressure. So this is the big problem with having low blood pressure, right? Or this is one of the big problems, right? Falls, fractures, right? Stand up, pass out, stand up, you're dizzy, you wobbly, you stumble, you fall over. It can cause lots of other issues, right? As we saw on this slide, right? None of that is good stuff either. But this is the one big thing that we worry about. So how do you know if you have orthostatic hypotension, right? So essentially it's a drop in blood pressure of greater than 20 points of the top number or greater than 10 points of the bottom number after 3 minutes. So if you stand up, you measure your blood pressure laying down, then you stand up and you measure it standing up. And if it's dropped by that amount, then you've got it. This also can happen for some people when they eat, right? You have a big meal, all the blood rushes to your stomach and you feel really lightheaded. And we've all experienced this when we overeat a little bit, we just feel tired. That's the issue, is your gut is taking all of your blood and there's not enough blood going to your brain. But this can be much more pronounced in some people with Parkinson's. So that some people even pass out after they eat. So about a third of people with Parkinson's have this orthostatic hypotension. And then about 80% of people with this condition MSA, which is a Parkinson's plus syndrome, multiple systems atrophy. So it's much more common in MSA, but also happens in Parkinson's. So another question, low blood pressure on waking. So that's not usually part of it. In my experience, that's, all of us through the night when we're asleep, your blood pressure drops normally. That's a very normal thing. And so some people it takes them a little while to kind of get going in the morning. So not a common symptom of orthostatic hypotension, that's kind of a common symptom in general. So we talked a little bit about it. One of the issues is this norepinephrine system. So earlier we saw the blue lines going through the brain, and that was the dopamine system. But there are lots of chemical systems in your brain, and one of them is the norepinephrine system. And this is represented here by this green. And you can see the green line that's kind of going down from the brain down to the spinal cord. And this is the stimulation that would come down into your blood vessels, essentially, right? So it's again thought of as a brain condition. This kind of system in your brain is just not functioning as well as it should. So we talked about Parkinson's disease itself can cause low blood pressure. Some of your medications can cause low blood pressure. And then multiple systems atrophy is another big cause of blood pressure. So then, there's other conditions out there that cause low blood pressure. So diabetes is probably the most common because diabetes damages the nerves. All those little nerves that go out to your blood vessels get damaged if you have poorly controlled diabetes. So this is also a common condition in diabetics. There's a very, very rare condition called pure autonomic failure, where essentially the only thing that's going wrong with you is that those nerves in your autonomic nervous system are not working properly. And then, people with spinal cord injuries can have this problem as well because they've damaged the transmission from the brain down into the blood vessels. So what do we do about this, right? So makes a lot of sense. If you're on blood pressure medications, you're taking medications that lower your blood pressure, you want to stop those. You want to make sure you're drinking lots of water. It's the only time a doctor will tell you that you're allowed to eat more salt. And then there's evidence that sleeping with the head of the bed tilted up essentially kind of trains your body to push harder, essentially, throughout the night and to supply your brain with more blood. And then things like, clenching your muscles before you stand up, crossing your legs before you stand up, essentially pushing that blood from your legs upwards to your brain. There are compression stockings and abdominal binders, as seen here, that can be very helpful. Again, the idea being is just passively pushing blood out of your stomach and out of your legs to getting it up to your heart so that your heart can get it to your brain. There are medications that we can try. So fludrocortisone essentially is a medication that acts on your kidney to help you reabsorb more water. So essentially reduces how much water you pee. It keeps, liquid in your bloodstream. Problem is, extra water means possible swelling. And there's a medication called midodrine, which works on the problem itself, constricts blood vessels so that they're not as floppy as they were, and that they then, kick the blood back to the heart, and then you can go up to the brain. One problem is if you take it and you lay down, your blood pressure can get too high. So that's a risk with the midodrine. There's a couple other medications. This droxidopa is not available in Canada. Pyridostigmine is a medication we use for other neurologic conditions that can sometimes help as well. But these top two, fludrocortisone and midodrine, are the two mainstays of treatment. So I think the big take-home point really is you got to talk about this, right? You got to let someone know, and you got to have your doctor check your blood pressure, right? That's the only way to know if you have it, for sure, right? And then there's some way we've talked about ways to treat it if you have it. So then let's talk a little bit about pain. So the way I like to think of pain is there's kind of 5 different categories of pain in Parkinson's disease. There's musculoskeletal pain, which is just, muscles, aches and pains, joints, everyone gets this. There's radicular or neuropathic pain. This is essentially pain caused by injury to nerves, whether it's a pinched nerve or some other damage to a nerve, like a diabetes or a chemical exposure that can damage nerves that causes pain. There's dystonia related pain. So a lot of people with Parkinson's get a dystonia, which is cramping, and it's commonly in the foot. And that obviously, muscle cramps are painful. Then there's, restless leg syndrome. Akathisia is just kind of an uncomfortable sensation. So this is much more rare, but it can come on in people with Parkinson's. People, they describe it as just kind of an uncomfortable, creepy, crawly sensation in their legs, mainly in their legs. And then there's these really, really rare central pain syndromes where people have this kind of boring, aching, deep pain that can be almost anywhere. It can be in your tongue, can be in your leg, can be in your arm, can be in your chest. And we can't find a structural or a cause for it. And we think this is just related to kind of abnormal processing in the brain, where your brain just thinks it's in pain, thinks there's something wrong, and it's just sending the wrong signals to you, essentially. So these bottom three often get better when you take your levodopa, right? Musculoskeletal pain usually doesn't improve with levodopa. Nerve pain doesn't improve, but dystonia sometimes improves. This kind of RLS, akathisia type pain improves, and the central pain often improves. So let's go. So, pain is common. I got other numbers here. So yeah, just ignore this. There's about 10 million people in the world with Parkinson's. Some of the evidence, it's a bit varied, but some people think, half to, 3/4 of people with Parkinson's may experience pain of some kind. But I think one key here is that the prevalence of pain in Parkinson's is much higher than in aged matched controls. So people without Parkinson's don't experience pain the same way that people with Parkinson's do. So the way I explain it to my patients is it's like you're just more sensitive to pain. Your brain, the way your brain processes pain, is different than people without Parkinson's. And there are differences. We all experience pain differently. I mean, we all know someone who, we all know people who, they smash their toe and it doesn't do anything to them, and then we know people who smash their toe and they're lying on the ground crying for 5 minutes, right? And so there is a spectrum of how your brain perceives pain, but in Parkinson's, you get pushed more towards the perceiving more pain side of that spectrum. So I'm just going to skip through some of these. So, why do people experience pain? We kind of touched on this a little bit. This is the way I was taught about pain when I was in med school. Essentially, your finger hurts and just a transmission gets sent through your arm to your spinal cord here and then up to your brain. And then you say, oh, I have pain. But it's a lot more complicated than this. There's so many other pathways and interactions here that can affect pain. You think of, when you're depressed, people who are depressed experience more pain. People who are stressed out or haven't slept well experience more pain. So there's a lot of other things in your life. If you have one pain, if you have headaches, and then you also develop back pain, those two pains kind of interact with each other and they build upon each other. So there's lots and lots of complicated interactions in the brain and in the body around pain. It's not just kind of this one-way pathway as we used to think. That is a good quote. Sorry, it's a multi-dimensional experience, right? Affecting, your thinking and your movement and what kind of mood you're in. How do we treat pain? Well, I think the first thing is to recognize it, right? So this was some interesting studies that, while maybe 80% of people with Parkinson's have pain, in one study, only about 60% of them take something for their pain. In another study, only half of people who actually had pain and Parkinson's take an analgesic. So there's half of people who admit they have pain but don't do anything about it or not taking meds for it, right? And then in another study, 20% of people who described pain as dominating their day, this was how they described their pain, in a survey. How does pain affect your life? Dominates my day. Only 20% of those people are actually taking a medication. So the first thing is to recognize it and to talk to your doctor about it. So back when James Parkinson was writing, his essay, 200 years ago, he talked about leeches. This is how they treated pain, right? Things have thankfully moved on a little bit. So one of the problems with treating pain in Parkinson's, there's not a lot of evidence. So I just want you to take this with just some understanding that this is not hard and fast rules, and this is all not set in stone. So let's go through these different types of pain, right? So what do you do for musculoskeletal pain? Physiotherapy, really important. And then, NSAIDs like ibuprofen, essentially. Those kinds of medications. This is the best treatment for this kind of pain. For radicular pain, right, where you have a pinched nerve or something like that, again, physiotherapy. And then, gabapentin, there's other medications. Gabapentin, duloxetine are a couple pain medications that can help with neuropathic pain. And someone's written acupuncture and massage. Yeah, no, there's great evidence for acupuncture and massage helping with musculoskeletal pain and other types of pain as well. Someone else has written cannabis. So yes, there is evidence that cannabis can help with certain types of pain, especially musculoskeletal pain. Essentially, it kind of acts as a muscle relaxant, is the way we think it helps with pain. Again, cannabis, one of the problems with cannabis is there's just not a lot of research in it these days. So probably is helpful in other ways, but we just don't have a lot of evidence for it, unfortunately. And I think that'll change over the next 5 to 10 years, though. So what about dystonia, right? So I show this picture of a neck twisting, because that's another type of dystonia, is a neck dystonia. So sometimes, just essentially optimizing your levodopa and your other medications can help. But, usually Botox is what helps with this. So Botox is a drug we inject into the muscles, in the neck or the leg or wherever you have the dystonia, wherever the muscle cramps are, that essentially relaxes the muscles, blocks the transmission from the nerves to the muscles, thereby relaxing the muscles. For this akathisia, this restless leg syndrome, again, it's mainly adjusting your dopaminergic medications. And then central pain, yeah, we don't really know. It's so rare, that we try. There's various medications you can try. There's not a lot of evidence to support any of that, though. So a few take-home points about pain. It's common. You got to talk to your doctor about it. Physiotherapy, exercise, massage, acupuncture, all this kind of non-pharmacologic stuff, it's really, really helpful, right? I mean, there's lots of evidence that just exercise, right, getting your heart rate up a certain number of times a week reduces your pain. Even if you're not exercising the area where it's painful, just exercise, riding a bike, swimming, reduces your pain levels, because you're, just being physically fit essentially makes you experience pain less. And then there's medications which can help, but we certainly need more research. So that's my spiel about non-motor symptoms. Let me try to get back to, oh geez. I don't know how to stop sharing. Let me see, stop share, there we go. Yeah, so does anyone have any questions? Comments?
Dr. Tuck, I think there was a question up here. I'm not sure if you got it. It was, one sec. Did you get this question? Does Botox bladder injection work for urinary dysfunction during the night?
Yeah. So I talked about how Botox can help with an overactive bladder. Definitely. So I've got another question. How do you differentiate PD from MSA? So there's no way to do that 100%. Well, there is one way, but that's essentially an autopsy, right? So the only way to know for sure is to take your brain out of your head and look at it under a microscope. So, generally, it's a clinical diagnosis. It's, people with MSA look different than people with PD. Now, early on in the disease, it can be hard to differentiate the two, but at some point, they diverge. And so people with MSA generally have more problems with autonomic dysfunction, as we talked about. They have more problems with balance. And I guess one of the other keys is people with MSA generally don't respond to levodopa. So with people with Parkinson's, levodopa usually works very well. And in people with MSA, it doesn't really do anything. So that's really, the key branching point there. So question, will you be sharing the PowerPoint? I'm happy to. I don't know, maybe I can Alana, can I email it to you for distribution, or how can we do that?
Yes, of course. You can email it to me sometime after the presentation today.
Okay, great.
And we can post the recording. We are recording this.
Oh, good.
And also the slides, if it's okay with you.
Yeah, for sure, for sure. So another question, urethritis is part of IBS. I'm not sure I understand that question. So IBS is, in my mind, is inflammatory or irritable bowel syndrome, which is not part of Parkinson's. And urethritis is an inflammation of the urethra, which is not part of IBS or Parkinson's either. So I'm not sure I understand that question. So maybe you need to please resubmit. Yeah, okay. Any other questions? I guess I'm happy if you want to raise your hand. I think I can also just allow you to talk if you want to ask a question over the video. If you're not interested in, if you're not much of a typer, or and you just want to ask a question, you can just click the little raise hand button, and I should be able to see that, and then I can just turn on your microphone essentially. So next question, depression, isn't it a non-motor symptom? Certainly, yeah, depression is definitely a non-motor symptom. Well, like I said, we don't really have time to go over every single non-motor symptom, but yeah, depression is relatively common. Again, this might be one of these pre-diagnosis non-motor symptoms. So there is evidence that people who have depression, or people who develop Parkinson's eventually, you often look back and they've had depression in the past. So, yep, common. I mean, it's common in the general public as well, not just in Parkinson's. And so again, another thing I really highly recommend people talk to their doctors about, and because there's lots of ways to treat it, right? Everything from just counseling and exercise to medications. And the Parkinson's Society has access to counselors that are really helpful. So if you feel like you're depressed and you need someone to talk to, Parkinson's Society BC can help out with that as well. Oops, has irritable bladder arthritis. Irritable bladder and urethritis. Yeah, so so overactive bladder. So this is the question about overactive bladder, I guess irritable bladder, and urethritis, which is inflammation of the urethra. So I'm not aware of a link between those two. Certainly irritable bladder is part of Parkinson's, or overactive bladder, but I'm not aware of a link with urethritis. That's probably a little beyond my expertise of the urinary system. So if you're having those issues, it's probably best discussed with a urologist. Why is the burning pain in legs worse during the night? And what, if anything, can be done about it? I assume when you talk about burning pain, you're talking about something like restless leg syndrome, or perhaps a peripheral neuropathy. So restless leg syndrome is commonly worse at night. We don't really know why. we don't really understand what restless leg syndrome is and why people get it. But there's medications. Essentially, the dopamine agonists are really good medications to help with treating them. So peripheral neuropathy, yeah, I'm not sure why that would be worse at night. That's usually just usually present all the time. It may be that people are just more aware of it at night because you're trying to sleep instead of being distracted. So again, yeah, there's lots of medications that can help with peripheral neuropathy pain. Gabapentin is a common one, pregabalin, duloxetine. So again, something to chat with your doctor about trying. Can REM sleep-related disorder be treated with medication? Yes, it can, definitely. So REM sleep behavior disorder is a condition where people essentially act out their dreams. So in people without this condition, in the general public, right, when we sleep, our brain paralyzes our body, so we don't move while we sleep. But in this condition, that gets a little disrupted. And so people with REM sleep behavior disorder will act out their dreams. So it's usually very violent, thrashing around, kicking, punching, calling out, lots of vocalizations. So the management of that, the first thing I have people try is melatonin. So just over-the-counter melatonin, taking that, before bedtime can help suppress the movements. And if that doesn't help, then there is there's a prescription drug called clonazepam that can be very helpful to suppress those. Essentially, it's a sedative, but can help those movements quite a lot. Any other questions? Let's see, I don't have a good sleep at night. I also have a bladder problem. Do you think fasting from 3 p.m. to 5 a.m. the next day is going to help my sleep? So certainly if you're getting up to urinate frequently at night, then trying to limit how much liquid you take in the evenings can be helpful. I guess it's a fine balance, right? As we talked about with low blood pressure, you don't want to totally dehydrate yourself, right? But yeah, limiting, making sure you drink a lot during the day, but then limiting how much you drink in the evenings can be helpful. Fasting, yeah, when you eat, certainly your body turns a little bit of what you eat into urine. But it's not a whole lot. And so, that's a long time to go without eating. For some people that's fine, but there's no harm in doing that, in going, I guess, 14 hours without eating. But that's hard for a lot of people. But it may help you, sure. So I'm taking CBD oil to help with sleep. It works. Good. Yeah. No, I know lots of patients who do. There's not a lot of evidence for it, but there's certainly a lot of anecdotes and people who try it and feel that it helps. I guess the one thing I say about cannabis and CBD is, we know that CBD suppresses dreams. So it actually stops you from dreaming. So not that it stops you from moving while you dream, it actually suppresses your dreams. So people who, it's all as a therapy they're looking at people who have PTSD, right, who have really horrible nightmares, because it just stops dreaming. So what does that mean? I mean, well, what's the consequence of not dreaming? We don't really know. We don't really know the function of dreams, but just say kind of, buyer beware. We don't really know what the CBD oil is going to do to you long term if you stop dreaming, essentially. So another question, does caffeine help with symptoms? Caffeine is a kind of a stimulant, right? It helps promote wakefulness. So If fatigue is a problem, yeah, I'll often have people, tell them just drink a bit of caffeine in the mornings to help with their fatigue. There's some evidence that caffeine helps with pain as well. Helps reduce the, sensitivity to pain. I don't think there's a lot of evidence that it helps like your motor symptoms or movement symptoms. So really I kind of stick with it as, if you're tired and sleepy, yeah, drink caffeine. That can be helpful. Is medication for erectile dysfunction just a variation of Viagra? Yes. So it's really, yeah, there's Viagra. There's a few different, compounds. They're all somewhat similar to treat erectile dysfunction. There are other medications that are a little more invasive that I again would refer someone to see a urologist to discuss. Essentially, there are injectable drugs that you can inject to help achieve an erection. And there are also, surgeries that can help with that as well. So, the limit of my expertise is, yes, drugs similar to Viagra, but there are other levels that a urologist could help talk to you about. Any other questions, concerns, thoughts? Anyone want to say anything? All right. Well, thank you very much for listening. Oh, can anything be done about Pisa syndrome? So for those of you who don't know what Pisa syndrome is, it's like the Leaning Tower of Pisa. So some people with Parkinson's, they just have a lot of trouble keeping themselves upright, and they kind of lean to one side or forward. When it's forward, we call it camptocormia. If you're leaning to one side or the other, we call it Pisa syndrome. There's not a whole lot that can be done about that. In the past, I've tried Botox injections for people with this. There are some people that have really tight muscles on one side of their back or their stomach, and we try to inject them Botox to try to, relax them so maybe they get a little straighter. It's really, I've really not gotten much good benefit from that. The one thing that seems to help is just reminders to stand up straight, right? Because most people with Pisa syndrome can sit up straight, they just don't think about it, and eventually, they just kind of, this is just kind of the way their body thinks it should be. But if you tell them to stand up straight, they can. So having like a frequent reminder, I've had patients who feel like wearing a backpack. There's always something touching their back, and it gives them that kind of sensory stimulus to keep them upright. Those are really the things that I try to tell my patients to try. You mentioned exercise. Does stretching work? Stretching's great. Yep. Stretching helps with pain and stiffness for sure. But I think more important and things that have more evidence for help are really more vigorous exercise, right? Getting your heart rate up is really important.
Dr. Tuck, I just had a question about facial masking as one of the non-motor symptoms. Is there anything that can be done about that to manage that? What's the scientific term for that again?
Yeah, masking. I mean, that's a form of the bradykinesia, right? It's just a form of slowed movements. So yeah, I mean, some people feel that the levodopa helps that, but there's not really much else to do for that. It's really just, yeah, the dopamine.
Okay, thank you.
Does a hot tub help with pain? Yeah, definitely. I mean, it's like massage. It's like, stretching, right? It loosens muscles. So certainly if you have that kind of musculoskeletal pain, tight muscles, certainly a hot tub can help. Then someone writes, I purchased a posture corrector. It helped. I assume this is in relation to Pisa syndrome. I'm not exactly sure what a posture corrector is, but yeah, if it's a device that helps you stand up straight, sounds great. Don't really recommend, things like braces. There are all these like back braces you can get. And the problem with those is you essentially lean on it. You get your muscles atrophy because you're not using them, right? This supports your back, and then you don't have to use your muscles, and then your muscles atrophy. So long term, it's not a great thing to really to have like one of these back braces or but kind of minor things where it's just like a reminder that you need to stand up is fine. What is loss of executive function? So executive function is kind of the frontal part of your brain that makes you be able to plan things and organize things. And so this can be part of cognitive issues in Parkinson's, is this kind of lack of motivation or lack of planning ability and lack of kind of a lack of spark, I guess. So it certainly can be a non-motor symptom. Apathy, which is kind of related to depression and, maybe part of cognitive dysfunction as well. I walk like a drunk person. What should I do to walk normal? It's a very broad question. It's a little hard to answer without seeing you or knowing you. But in general, for balance issues, exercise, physiotherapy is the mainstay. The medications often don't help balance, don't help walking. They may somewhat, but really it's exercise and seeing a physiotherapist, perhaps using a walker or something like that.
Dr. Tuck, if someone was using cannabis, you mentioned earlier to help with sleep or pain, would the cannabis then negatively impact the executive function, like with planning abilities and so forth?
Yeah, I mean, obviously, cannabis, gets you high, makes you a little loopy, right? So I think that's the idea behind just the CBD oil, right? Because there's kind of two main compounds in cannabis, right? CBD and THC. And we think of the THC as being the compound that makes you high and makes you loopy, and CBD may have all these other effects. So again, there's just not a lot of evidence, right? Not a lot of research into it. So I certainly warn people that, if you're going to try cannabis, you just want to watch out. It might make you high, and then you're not going to be as functioning as sharp as you used to. I see there's a couple questions and answers in the Q&A box that looks like I didn't see. So my husband has discoloration of his hands and increasing white part of nails. And then the question is this PD related? That does not sound PD related. Sounds like something you need to chat with your GP about, maybe a blood circulation issue, perhaps. That might be repeating. Oh, yeah, so it's the same question. Yeah, no hand and finger discoloration. That's not part of PD that I am aware of. And I would be more concerned about a blood circulation issue. All right, well, thank you very much, and wish you guys all the best.
Thank you so much, Dr. Tuck. Thank you for being here and sharing all of that helpful information and putting on such an informative presentation for us. And thank you so much for answering all of our questions today. And thank you all for attending. Our second talk in the Symposium Series is coming up as well, so hope to see you there as well. Have a great afternoon. Thanks, everyone. Bye.
Bye.